Greetings. Let us learn about EUS, endoscopic ultrasound or ultrasonography. So when you want to set up for a case and you want to bring the EUS scope, you need to ask the endoscopist whether they want to have a radial scope or a linear scope. When you go into the room, the storage room, to pick up the scope, you are looking at the end of the insertion tube to figure out whether it is a radial scope or a linear scope. So let us learn about the details of a radial scope first. So this looks the same, similar to any other scope, except the end of the insertion tube. So let us look at it in a little more detail. Here is the end of the radial EUS scope or echoendoscope. As you can see here, the plane of imaging of a radial EUS scope is perpendicular to the scope axis. So this gives a 360-degree view of the area that you are surveying. All these scopes, echoendoscopes, we place a balloon at the end, and it is important to make sure that there are no air bubbles when you fill that with saline. So that is very important from an endoscopy technician point of view when setting up the EUS scope. So we've learned about the radial echoendoscope. We've learned that it scans perpendicular to the scope axis. How about a linear echoendoscope? Again, let us look at the end of the insertion tube in a little more detail. Here is a linear echoendoscope, and when you look at the plane of imaging, this is parallel to the scope axis. Unlike the radial one, which is perpendicular, a linear one is parallel to the scope axis. So that means you can actually see along the wall, but not a 360-degree view. Like the radial scope, we place a balloon, and it is important to make sure when the balloon is filled with fluid or saline, there are no air bubbles in the balloon, because air bubbles interfere with the ultrasound examination. Another feature that is special about the linear echoendoscope is its ability to biopsy or take cytology specimens with a needle that is passed through the scope. So now that we have learned about the differences between a radial echoendoscope and linear echoendoscope, let us learn about their role in imaging. These scopes are basically used to examine the wall of the GI tract, because these scopes can tell the layers of the GI tract, and they can also image outside the wall, especially structures outside the wall, whether they are lymph nodes, blood vessels, organs adjacent to the GI tract, like pancreas, liver, spleen, etc. So let us learn a little more, taking esophagus as an example. Here is the esophagus. You can see the wall of the esophagus. You see the lymph nodes. And when the esophagus develops cancer, it starts from the mucosa and goes through the wall and tries to extend deeper. So as you can see, the tumor is going from the mucosa to the submucosa to the muscularis propria and to the adventitia. And as the tumor spreads, it can involve the lymphatics and the lymph nodes, leading to enlargement of lymph nodes. The difference between a non-cancerous lymph node or a benign lymph node versus a cancerous lymph node is the change in the shape of a lymph node from an oval lymph node, benign lymph node, to a shorty, round lymph node that is cancerous lymph node, as you can see here. So, when we are evaluating a patient with esophageal cancer, we try to figure out the tumor stage, that is the cancer involving the wall of the esophagus, that is the T stage. And we also evaluate the involvement of the lymph nodes, or the nodal stage, or the N stage. So we've learned a lot about esophageal cancer, tumor stage, lymph node stage. EUS is not able to figure out whether there is a very distant metastasis involving the lungs or the liver, and unless it is very close to that area, especially left lobe of liver. So the metastatic spread to distant organs is evaluated by using either a CAT scan or an MRI or a PET scan. Now that we have learned about these aspects, what is the difference between a regular EGD examination of the esophagus and ultrasound examination of the esophagus? When you pass the endoscope into the esophagus and you find cancer, all you can do is assess the cancer from the lumen side and maybe take biopsies, i.e., you can make a diagnosis of the esophageal cancer. With the regular endoscope, you cannot see the depth of spread of cancer into the wall, that is the T stage. You cannot see what is happening outside the esophagus, especially the lymph nodes, the nodal stage. However, when you use a radial echoendoscope or radial EUS, you can scan and figure out the tumor staging, that is the spread of the cancer through the planes of the esophagus, whether the tumor is limited to the mucosa, submucosa, muscularis propria, adventitia, lymph nodes, and involvement of the aorta. You can also see the same findings with a linear US. Again, linear US can figure out the tumor staging and the nodal staging. One other additional advantage of a linear US scope is the ability to do fine needle aspiration, otherwise known as FNA. And in this, you pass a needle and sample the lymph nodes. In other words, you do biopsy of those lymph nodes. And it's important to take the fine needle aspiration from lymph nodes that look cancerous. I mean lymph nodes that look round and shorty. And one should take the lymph nodes from a normal looking area of the esophagus. The needle should go from a normal looking esophagus. If it goes through the cancerous wall of the esophagus, then it may give a false positive result. So when we are staging the lymph nodes in esophageal cancer, we try to find the highest lymph node that is closer to the mouth and that looks cancerous to figure out how far the cancer has spread so that the radiotherapist could use that as the top extent of radiation. So now we've learned a lot about the role of US, radial US, linear US, fine needle aspiration. We could also use EUS to evaluate the pancreas, either with the help of a radial echoendoscope, in which case you can see the pancreas, the pancreatic duct, the normal pancreas surrounding the duct. The commonest reason for pancreatic EUS is to establish the diagnosis of pancreatic cancer. In that case, we need to use a linear echoendoscope, pass it into the antrum or the duodenum, and find that cancer under ultrasound, and use a needle to do FNA and sample the pancreatic cancer, and thus establishing the diagnosis. In addition to establishing the pancreatic cancer diagnosis, EUS could also help in nodal staging and also figure out whether there is superior mesenteric artery, superior mesenteric vein, or celiac artery involvement by the cancer, in which case the cancer is not amenable to surgery. Another reason for use of EUS is to evaluate cystic lesions of the pancreas to figure out whether it is a pseudocyst or a mucinous cystic neoplasm, serous cystadenoma, IPMN, islet cell tumors, etc. We could also consider taking fluid aspiration from the cyst and biopsies from the cyst wall, especially if they look suspicious. And nowadays, people are exploring the role of either introducing chemotherapy or also using radiofrequency to ablate these small tumors. In summary, there are lots of indications for EUS. One is to stage the tumor, establish the nodal spread by taking a biopsy or fine needle aspiration, evaluating and treating pancreatic cysts, mass, and pseudocysts. And in the last few years, US guided anastomosis, either gastrojejunostomy or hepatico-gastrostomy or duodeno-choledochostomy. These are different techniques that are being used to create anastomosis and relieve obstruction. Coming to the complications of EUS, one complication is perforation. This tends to happen when there is an esophageal cancer that looks obstructed, and then we try to push this endoscope through. It can result in perforation. It's important to keep in mind the outer diameter of an echoendoscope is much larger than a regular EGD scope and also much stiffer. Another complication is bleeding, and if you do fine needle aspiration of cysts, especially pancreatic cysts, there is a risk of infection, so they need to be pre-treated with antibiotics. And in some cases, pancreatitis can happen, especially after fine needle aspiration or biopsy of the pancreas, although rare. And these procedures are done under sedation. One should keep in mind reaction to sedation as another complication. I hope this is useful. Thank you.